Welcome! In this explainer, which is number 3 in our series, we're going to decode the really elegant principles behind canal geometry, functional pairing, and Ewald's laws.
So today we're diving into the brilliant architecture of the vestibular system, all based on the comprehensive clinical review from Australian Dizziness clinics. We're about to see how the shape and layout of the semicircular canals is anything but random. In fact, it's the fundamental blueprint that allows us, as clinicians, to decode nystagmus and understand what our tests are really telling us at the bedside.
All right, let's start with that blueprint. At its absolute core, you can think of the vestibular system as this exquisitely engineered, purpose-built biological gyroscope.
So this presents a pretty fundamental engineering problem, right? How does the brain, which is locked inside our moving skull, track every single possible rotation of the head with perfect accuracy and, well, lightning-fast speed?
And the answer is just so elegant. Nature solved this problem with a perfectly engineered biological gyroscope. This is a design that's been refined over 500 million years of evolution to give us a near-flawless sense of motion. It's incredible.
So how was this system physically built to pull off such a remarkable feat? Let's take a look at the hardware. It all starts with the very precise geometry of the canals and this clever idea of functional pairs.
Okay, so on each side of your head, the 3 canals are positioned at almost perfect 90-degree angles to each other. And this orthogonal arrangement, it's no accident. It's the core design principle. It creates a perfect 3D sensor that makes sure any head rotation, no matter how complex, gets measured along these 3 axes.
But the system gets even smarter. As you can see here, it pairs up canals that lie in the same plane but on opposite sides of the head. So the 2 horizontal canals work together as a team. The vertical canals, though, are paired diagonally. You've got the right anterior with the left posterior, that's the RALP pair, and the left anterior with the right posterior, the LARP pair. So when you turn your head, one canal in a pair is excited while its partner is inhibited. It's this brilliant push-pull system that actually doubles the sensitivity. And clinically, this is absolutely crucial. A unilateral lesion doesn't just cause a loss of signal, it creates a powerful imbalance between these pairs, and that's what drives spontaneous nystagmus.
Okay, so if the canal geometry in these functional pairs are the hardware, then you can think of Ewald's laws as the operating system. They're the fundamental rules that govern how all this hardware behaves and translates motion into neural signals. Let's break this down. The first law, eye movements happen in the plane of the stimulated canal. Simple, right? But it's profound. This is exactly why in BPPV, the plane of nystagmus we see points directly to the culprit canal. Now, the second law, and this one's for the horizontal canal. Flow toward the ampulla, that's ampulopetetal flow, is excitatory. This is the entire basis for the Cow's mnemonic we use in caloric testing. Then you have the third law, which flips this whole thing for the vertical canals. Here, flow away from the ampulla, ampulofugal flow, is what's excitatory. And this perfectly explains why posterior canal BPPV gives us that classic upbeat torsional nystagmus. Now let's zoom in on a really critical piece of this puzzle. It's one that explains so much of what we see at the bedside, especially after an acute vestibular loss, and that's the inherent asymmetry between excitation and inhibition.
If we look at just the horizontal canal, you can see this difference really clearly. The excitatory ampulopetal flow, the kind we get with warm caloric irrigation, it triggers a strong, robust neural response. But in contrast, the inhibitory ampulofugal flow, like with cold calorics, causes a comparatively weaker response. It's just not a symmetric system.
So the crucial takeaway here is this. The excitatory response is physiologically much stronger than the inhibitory response. The system is literally built to be far more sensitive to acceleration in one direction than deceleration in the other. And this inherent asymmetry is why warm caloric responses are typically stronger than cold, and it's a huge reason for the sheer intensity of symptoms in an acute unilateral lesion.
And this brings us perfectly to caloric testing. You see, it's not just a diagnostic tool. It's a brilliant clinical hack that directly manipulates the precise anatomy and all these physiological rules we've just covered to isolate and assess one specific part of the system.
So how does this hack actually work? Well, it all starts with positioning. The horizontal canal naturally sits tilted about 30 degrees upward. So by having our patient lie supine and then flexing their head forward by 30 degrees, we bring that canal into a perfectly vertical orientation. This is the essential first step. It makes the canal susceptible to the gravity-driven convection currents we're about to create.
And here is that hack in action.
When we use warm water, it makes the endolymph near the ear canal less dense, which causes it to rise. This creates an ampulopetal flow toward the ampulla, which, as Ewald's second law tells us, is excitatory. Cool water does the exact opposite. It makes the endolymph denser, causing it to sink. This creates an ampulofugal flow, which is inhibitory. We are literally creating artificial endolymph movement just to test the integrity of this reflex. It's pretty cool.
So, what does this test really tell us? Well, it's incredibly specific. It isolates and tests only the horizontal semicircular canal, and it does so at a very, very low frequency of stimulation. But what's just as crucial to remember is what it misses. It tells us nothing about the vertical canals, nothing about the otolith organs, and nothing about high-frequency function. And that's exactly where tests like the V-HIT become essential.
Okay, let's just distill this all down to the key takeaways. First, Ewald's laws are your predictive tool. They let you look at a nystagmus and immediately figure out which canal is involved. Second, that push-pull pairing means a unilateral lesion isn't just silence on one side, it's a powerful, predictable imbalance that drives the clinical signs. And finally, remember that the caloric test is a targeted, low-frequency, horizontal canal-only test. Understanding its limitations is just as important as knowing what it tells you. So, we've covered the macro-level canal geometry and the laws that govern their output. I hope you'll join me in our next installment, number 4, Sensory End Organs. That's where we'll zoom right into the microanatomy of the cupula and explore how the otoliths are built to be these incredible bidirectional sensors. Thank you for joining me for this deep dive into vestibular anatomy. To explore more resources for both clinicians and for your patients, please visit us at AustralianDizzinessClinics.com. And if you found this explainer helpful, we'd really appreciate it if you'd subscribe and leave a rating.